So I believe the clock is now 3 o'clock Central European time, and we will start this webinar on telemedicine, background, evidence and evaluation. Thank you so much for all of you attending this seminar or webinar, which is arranged by the Danish Society for Quality in Healthcare, the research committee in this society. You could ask the question, why do we need a webinar on telemedicine now? And in particular, why do we need a webinar arranged for an international audience with a focus on the Danish experience and plans? I think the reasons for that are twofold. One is the experience that I think we have learned across healthcare systems during the pandemic, that telemedicine carries perhaps an even larger potential than what we have thought so far, with regards not only to ensuring effective use of resources in challenged healthcare systems, but also a great potential for ensuring safety for both patients and staff in circumstances like the pandemic. Second, Denmark have had for years, also pre the pandemic, and quite ambitious national strategy regarding implementation of telemedicine. And this strategy is now embarking on its most important step, in the sense that we're now going to have nationwide implementation of telemedicine for patients with COPD, which I presume is probably the first nationwide implementation of a strategy of this kind we have seen so far. So there are some challenges in doing so. There are also some experiences that we would like to share with our international friends and colleagues. And that is really the background for setting up this webinar. So I think we will try to make the most of our time. A bit of practical information. We have a relatively packed program, a relatively short time span to perform the webinar within. So we will try to have some efficient time managing. On the other hand, we of course also would like the webinar to be engaging, and we would very much hope that you are interested in having an active dialogue. We need, of course, to do that in a way that is fruitful for all of us. So I think the most efficient would be if you could use the chat function and send any questions and comments you have during the presentations and afterwards. And then we will try to handle as many of them on the way as we go along. But with that, I will like to introduce the first presenter, and we will start with a presentation about the plans and status for the comprehensive national telemedicine rollout in Denmark. And that presentation will be given by Peter Munk Jensen, who is section head in the Danish Health Data Authority. So,
thank you very much.
What is your Peter's?
Thank you. Can you all hear me?
We can.
I'm afraid I have a problem with my camera and it doesn't seem to be working. I'm very sorry about that. I could try to restart my computer, but that would take a while. So I guess I'll have to go on without the camera.
I think we should.
Okay. Well, first of all, thank you for inviting me. As mentioned, my name is Peter Munk Jensen, and I'm from the Danish Health Data Authority, which is an agency under the Ministry of Health, where we are dealing with health data in many different ways. We have some very large health data registries in Denmark that we are in charge of, and we are also running a national health IT infrastructure, so for data sharing across the healthcare sector in Denmark. And we are also into this area, telemedicine, which is the subject of today. Do I share my own screen?
Yes, you do, Peter.
Just a second.
Yeah.
Trying to get it on.
Mm-hmm. Yes, it is on.
Good. Okay, this is my agenda. First of all, I'd like to say a few words about why is telemedicine interesting at all to work with, also from a political perspective. Then my primary focus of today will be telemedicine to patients with COPD. And I will try to give you an insight into the way we're working forward in Denmark and the status, and I also have mentioned the challenges that we are facing in this matter. Then I will say a few words about the next area we're looking into, which is citizens with heart failure. And finally, I'll try to summarize some experiences and learnings that we think we have done so far. So that's the plan. First of all, I would like to give you an extremely brief introduction to the Danish healthcare sector, because I think that's important to have a little bit background knowledge when talking about telemedicine and the way we are working with it in Denmark. The overall design, so to speak, of the healthcare sector is that we have 5 regions who are the main actors. They are running all public hospitals in Denmark, which have more than 95, 96 or 7% of all hospital activity in Denmark in the public hospitals. And they are in charge of psychiatric care, and also general practitioners who are private enterprises, but working under a contract with the regions. And on the other side, we have the local level, which are the 98 municipalities in Denmark who are in charge of primary care, preventive care, and elder care. So that's where many of the patients that are in these target groups they are, and it is often the municipalities that are in contact with these patient groups. So that's the overall layout, as I think many or nearly all hospital systems or healthcare systems are facing, we are also in Denmark facing challenges ahead regarding the way our demography is developing. As these figures shows, you can see the number of very old people in Denmark is growing at a very high rate in these years. That's the dark blue line you can see, and on the other hand, we also have a increase in the number of patients with a chronic disease. So this is, of course, when politicians and decision makers, they see figures like this, they start to looking for answers, because it's obvious that all these people, they cannot go into the hospitals because we simply do not have enough capacity to treat all those patients there. So we have to look for different solutions to these challenges. And this is where telemedicine becomes interesting, because it is a way to, roughly speaking, to keep patients out of the hospitals, but still have the expertise, the knowledge from hospitals in hand when needed, so to speak. And it's also a way of providing care and treatment for these patients groups closer, or even in their own home, by the use of telemedicine and monitoring devices, etc. So this is why, from a political perspective, telemedicine is highly interesting, because it is part of the answer to these challenges. So this was just a few remarks as an introduction. So what have we done? In what way have we moved forward? Back in 2012, when this debate started out, primarily the government at the time, they made an action plan for telemedicine, as you can see in the corner, called Telemedicine: A Key to Health Services of the Future. And there was also a little bit of funding as a part of this action plan. And at the same time, some people in the north region of Denmark, they were considering doing a large-scale telemedicine pilot for patients with COPD. So what the government did was that they put money into this large-scale test, this large-scale pilot in the north region, not for buying infrastructure or equipment, but for evaluation. That was primarily what the money from the government, from the Ministry of Finance at that time, it was spent, was used for. So what they did in North Denmark was that they made this project called Telecare Nord, or Telecare North in Denmark, where COPD patients had equipment in their home to carry out daily or weekly health measurements of their health status. And then all these data that were being measured was collected into a shared database that all relevant healthcare professionals could access. And the important part of this was that it was the responsibility of the municipalities to monitor these data. So it was nurses at the municipalities who looked at these, who are looking at these data, to make sure that the patient's disease isn't getting out of hand, so to speak, is under control. And if that would happen, then it would be the responsibility of the municipality to react, to contact the patient's own doctor, the general practitioner, or the hospital. So that was the main idea, was to avoid routine checkups at hospitals, and also, of course, to be able to avoid patients getting so severely ill that they had to go to the hospital. And what this pilot showed overall was that the effect was fewer hospitalizations and outpatient visits for some COPD patients, not all, but some. I think we'll get back to that in the presentation later on. And also for the patients themselves, there were great benefits, increased quality, flexibility and security, and overall a better everyday life, so to speak. So based on these positive evaluations, the government and the regions and the municipalities in 2015 made an agreement that this had to be rolled out on a national scale. And some of these and the highlights from this agreement is in these green boxes. As mentioned, Telecare Nord and the results from that large-scale pilot was the background starting point. Furthermore, there was also formulated a national joint business case in order to have an insight into the national benefits of this, of course, and also the costs. And furthermore, also to have an idea of what was the split, the division of these costs and the benefits between the regions and the municipalities who would be in charge of this telemedicine program. And also, what we also did was that the Danish Health Authority, the highest health authority in Denmark, they made a clinical recommendation for this telemedicine program. So what would, in a clinical way, would be the best way to design this, telemedicine for this patient group. So that was basically the foundation of the agreement, the business case and the recommendations, and also that the responsibility was placed at the regions and the 98 municipalities. And then it was also agreed that the program had to be rolled out before the end of 2019. And how far we have come, I will get back to in a little while, but I think it's fair to say that we are not there yet, but we're still working on it. Okay, so when we had this agreement, then we had to consider what is the best way to organize this implementation? What would be the best way to make it successful? And on one hand, ensuring that this would be, as mentioned, it is a local responsibility to make this work, to do this implementation, and on the other hand, ensure that we from the ministry side had enough insight into the progress being made in this program. So what we did was that we formed 5 local sub-programs in each region, and also the municipalities in each region. And they are like the cornerstone, the foundation of this program. So they are the main responsibility actor, so to speak, in this implementation. They are in charge of all sorts of logistics, education of both health personnel and also the patients taking part in the telemedicine program, and also in charge of buying equipment that are being used. And on top of that, we formed what we called a national portfolio steering committee that meets 3 or 4 times each year and discuss the overall progress in the 5 regions. And of course, this is where we have representatives from the ministry and also from the municipalities and the region's interests organizations. And then we have a joint secretary underneath that are supporting this portfolio steering committee. And what I was also forgot to mention before was as another part of this agreement upon on national implementation was that it had to be based on a national IT platform for telemedicine and for data sharing across municipalities and regions and also general practitioners. And I think the next presenter, he will get a lot more into that. So that's the overall layout of how the program, the rollout is organized in Denmark. So it is very much based as close to those in charge of healthcare services in order to ensure local ownership, so to speak. Okay, so how far have we come? This is, as I said, this national portfolio steering committee, they meet 3 or 4 times each year, and each time they look at the latest progress monitoring. And this is the latest one from September. And I'm not going through all these deadlines and milestones I mentioned here, but as the bottom line is the most important, because this is where you can see when the 5 regional programs they expect to have their telemedicine program fully implemented. August 22 for some of them, December 21, November 22 in the capital region, which at the moment looks like will be the last region to reach full implementation. So of course, if you think about the deadline I mentioned before, that was agreed originally, which was at the end of 2019, we are looking into 2 to 3 years delay according to that deadline. So yes, that's where we are at the moment. The next area we're looking into, as mentioned, is patients with heart failure. And once again, we look to the north region of Denmark, where the telemedicine they are still running there for COPD patients was so successful. So they thought, what would be the next group we could include in this program, and that would be or is patients with heart failure. And at a national level, we are at the moment more or less doing the same as we did with COPD. We have a relatively positive evaluation of the large-scale testing in North region, and where the Danish Health Authority has also formulated clinical recommendations on telemedicine to this patient group, and we are also looking into making a national business case for this patient group as well, just as we did with COPD patients. And then we have asked each of the 5 sub-programs or regional programs to describe a plan for how and when they can have this telemedicine for patients with heart failure implemented in their region as a supplement to the telemedicine they are implementing at the moment for patients with COPD. So, and that's of course, that is in order to enable us to agree of a shared deadline for implementation of that patient group as well, just as we have with COPD patients. Yeah, my final slide. I will try to say a few words about the experiences and learnings we have made so far. First of all, as you probably or hopefully have learned, it has taken a long time. This when we think about the original large-scale testing in the north region of Telecare Nord and the date when these 5 regional programs expect to have their telemedicine program fully implemented, we look into a 10-year time period. So it takes a very long time, and that is one of the challenges we are facing. It takes a long time from pilot to implementation. Hopefully, as my last bullet says, COPD has paved the way, especially when it comes to IT and organization, and we have from COPD some models and ways of doing things that we can reuse for the coming patient groups. It is not about IT, but as said, one of the reasons why we are seeing a delay is that the developing this shared national IT platform for telemedicine is taking a little bit longer than we have hoped for. It is a very big and complicated project, and it is a little, as mentioned, it takes longer than we had hoped for. Yeah, and but also I think the way we've organized it has been successful. It is our understanding that it has created a sense of local ownership. It is not a national initiative that they have to do because the government says so. I think they really feel local ownership of this initiative. Okay, that was a very brief introduction to the way we are trying to move forward, and I think my time is nearly up.
Thank you, Peter. Thank you so much for this helicopter perspective on the status of the rollout in Denmark. We have a few questions which we might try to address. I'm not sure we can get all of them right now, but we'll try. I have a question here from Peter van Gorp, and he asks, what are the functionalities of the telemonitoring system you are describing? Could you please briefly enumerate the key functionalities used in COPD and plan to be used for heart failure?
I think what they are measuring, if I understand the question correctly, what they are measuring in Telecare Nord is weight and oxygen levels, and the third thing I can't remember.
They're measuring blood pressure.
Blood pressure, of course. Yeah. Is that an answer to the question?
Yeah. Do we know what is planned for heart failure?
Can I add to that, Søren?
Please, Lars.
Yeah, I think that it has been decided that the region can decide what specific tools will be in the kit. So there will be differences between the regions. There will be, in general, there will be a way to measure oxygen level and weight and blood pressure. But in one region, there will be a video link, for instance. In another, there will be other instruments that they will try out. So it's not.
That's correct.
Yeah.
There are differences in the way that these regions are implementing their telemedicine offer.
Good. All right, I think we'll jump. Next question. Which telemedicine solution is used in North Denmark? That is from Martin Wolf Gerdes.
I think the next presenter will perhaps go and answer that question.
That'll probably be good. So we will have, I think we'll proceed to the next presenter. and then hopefully maybe we can come back to some of these questions in the end if we have time. Otherwise, we can always follow up on emails, I'm sure.
Sure, please.
Good. Peter, could you? Thank you. Perfect. So focusing on primarily the organizational perspective, we will move to a more technical focus with the next presenter, which will be Christian Callesen from Optimum IT. Of course, the prerequisites for implementing a nationwide solution for telemedicine depends also critically on the existing data infrastructure and hardware and IT structure. Hopefully, Christian, you can enlighten us a bit about what we know about that from a Danish perspective so far.
Yes, indeed. One moment. It turns out I needed to tell Zoom it may change, it may share my screen. So if you'll bear with me 1 second. Okay. You only discover that when you actually try to share something. And I'm unfortunately I need to reopen Zoom, so stay with me for a second.
All right, otherwise I can, all right. He will be back very soon, I hope. All right, in the meantime, if you follow on the all the nice comments on the chat function, I can see that Richard Pantlin from NHS is also commenting on the use of rollout of blood pressure monitoring in patients in England, and IT platforms for communicating results to clinicians, with plans also to expand that into heart failure. So very similar challenge to what is ongoing in Denmark. And I can see that Richard is also commenting on the use of oximeters for measuring hypoxia early as a consequence of the COVID epidemic, as an example of a telemedicine approach that has been pushed forward. So a lot of activities going on related to what we are talking about today. Okay. Let's hope we can just be patient for a few seconds, and then we will have Christian Callesen back online again. Here he is.
My apologies, technical problems as usual. Everything should be fine now. I certainly hope I can share my screen. Yes, I can. Excellent. I do apologize.
That's all right.
My name is Christian Callesen. I am an IT architect. I have been closely connected with the telemedicine project, first as part of the public tender, and then secondly, as vendors were chosen as part of the development project to build both an infrastructure and a telemedicine solution. I'm an external consultant and not employed directly by the municipalities and regions, but I have been an advisor to them. The experience shows that telehealthcare is actively in use in Denmark, as you probably all know. Many projects have been undertaken. One of the challenges has been traditionally that while many projects are very successful, going into full-sized operations requires a lot of additional things. Handling operations, carrying out changes, operations processes, and so forth. So while there is a significant benefit for patients / citizens and clinicians, and experience suggests that nationwide scale is feasible, the scale levels, as you can see in the lower left side of the screen, suggest that there are several thousands of potential citizens or patients that could in fact benefit from this. Not only COPD, but wound care, which has also been run as a telemedicine initiative, and diabetes show that the amount of scale for patients is staggeringly large. So this suggests that when we will want to scale this, it turns out that we must consider scalability both in terms of rolling out a national solution that both can help outpatient treatment or patient treatment in hospitals. It also needs to consider citizen care by the local municipalities. As Peter Jensen said, treatment is usually done in regions by regional hospitals, some few private hospitals, and care, such as, for instance, wound care, is done by the municipalities. So a scalable solution needs to encompass both of these. There are 98 municipalities in 5 regions, which means there are 103 different actors in the system that are all independent companies, so to speak. There are also many potential telehealthcare areas. I've just mentioned 3 over on the left, but the list is very long. There are people with intestinal things, heart failures, and so on. Finally, we need to consider that we want to nationwide share information about patient health. While the systems need data locally, so the clinicians can carry out monitoring of patients and treatment, we also want the ability to share data across a national infrastructure that is placed with the National Health Data Authority, Peter Jensen's organization. So there is a nationwide sharing that's desirable for clinicians. So it's such that if patients are getting a telehealthcare initiative or offering from, say, one region, that if that patient happens to go in another region, that they can see that you are in fact receiving telehealthcare, and they can see the details. So we do want to share information across the entire country. Finally, if we are to scale this, it turns out that for COPD, we're using devices, as Peter mentioned. So an oximeter, a blood pressure sensitive measurement device, and also a weight, and potentially there could be others, such as, for example, measurement of blood sugar for diabetes. We need to handle the fact that while clinicians will order these as packets from, say, a vendor, they are not actually the ones to make sure that the citizen delivers this to the citizens gets this delivered. So clinicians would really much like to order delivery. And so this means that we want to enable commercial vendors to supply some of the logistics around healthcare devices. And these were the scaling considerations that were in place when we wanted to think about how do we go about creating a national infrastructure for this. So we invented what's called FUD in Danish, Fælles Udbud af Telemedicin, which translated into English means common tender for telemedicine. We called it tender then because it was an official EU tender using the EU tender processes. After that, after the tender was carried out, the U was changed to udvikling in Danish, which means development, because we then changed to a development focus. There were requirements, and I saw that in the chat. The requirements was that we wanted support for clinicians and for patients. For clinicians, we wanted to ensure that you could use login and give access control under local control. This is a very new development in Denmark. Instead of having a central user database, we want to use the existing login systems such as Active Directory and like systems in local municipalities and regions to do login. No more central large user database of all telemedicine users. It's a local decision made by the local municipality or region. We wanted to ensure that clinicians can set up and access assigned telehealthcare packets. So for example, for COPD, we would create a packet that contains assignment of a certain set of devices, plus assignment of when the citizen is supposed to monitor and send in monitoring of themselves, such as you're supposed to measure your own weight once a week. You're supposed to measure blood pressure daily, for example, and you are supposed to measure your oxygen levels in your blood 3 times a week. And perhaps you are also required to measure an exercise in which you sit down and stand up repeatedly for a number of times and report that number in. And that's all in a telehealthcare packet that a clinician can then set up and then assign to a particular citizen.
Johannes och Nanna, har ju lyst på en bolla?
I think somebody needs to be muted. I will, in addition, we wanted to control ordering devices for patients and track and trace on delivery. We wanted to ensure that the clinicians can monitor patient measurements and questionnaire responses. and this should be team-based, so that it's not the individual clinician who has the responsibility to monitor a given patient, but typically a team, because that mirrors the way that patient monitoring is actually carried out in Denmark. For the patients and citizens, we wanted to support initial login using our national citizen log-on solution that is supplied by a state agency. Subsequently, we want to support login by, for example, PIN code or Face ID or fingerprint, because experience in Telecare North, in the northern region of Denmark, suggests that typically elderly people who have COPD, they have a not very good, they can be challenged in terms of using the national healthcare login as it is right now. And by using, say, fingerprint or Face ID, it's a lot easier for them to use rather than having to perform a slightly more complicated login every time they're supposed to make a measurement. So we suggested that it should be possible to use, say, a FAR4 or 6-digit PIN code for a tablet instead of actually having to do a national login every time. So, of course, we also need to ensure that we can assist the patient in making their measurements and responding to questionnaires. And finally, we wanted to support that clinicians can interact with the patient so that the patient can ask questions or participate in a video meeting, just like this one, with his or her clinician. So what we ended up procuring, we procured a platform, the common telehealth infrastructure. I'll show you a picture in a moment. It can contain the packet definitions and assignments. It will receive and contain measurements from citizens. It carries common functionality across different healthcare areas. It facilitates and carries interaction, text or video. It facilitates the logistics in terms of allowing a clinician to order a telemedicine packet containing devices for a citizen. It ensures national sharing so that whenever a citizen turns in a measurement, it can be nationally shared for all those clinicians who are permitted to look at the citizens' data. And finally, it contains a scalable cloud-based infrastructure so that we can scale this infrastructure in terms of more capacity when new healthcare areas comes on. The second thing we did, we procured a solution for clinicians, we procured a solution for patients, and for the API, for the logistics vendors, we created a simple user interface and an API so that logistics vendors can receive orders for delivering equipment to a citizen and then delivering this to a citizen. And COPD is just the initial case. We expect others to follow. So this is what we procured. Basically, the key area. There was a telehealth clinician solution. There was a telehealth patient solution connected to the common telehealth infrastructure. There is a simple solution for service support and logistics. And it all facilitates data exchange with the Danish national health infrastructure, which contains, as you can see, NemLogin, that is our clinician login system. There are some shared healthcare documents, patient consents, common patient data, patient appointments, in this case, video appointments, video meeting solution, and an access log so that any citizen in Denmark can see which clinician has accessed my data. The way we share this, and this is a slightly more complicated picture, is, as you can see on the left-hand side, I've marked up blue fire boxes. This is because the common telehealth infrastructure uses FHIR as its central protocol. It is an efficient, lightweight protocol of health level 7. We use it extensively to interact between both the solution for telehealth clinicians and for telehealth patients. The common telehealth infrastructure is based on FHIR version 3, which Denmark has made a profile of specifically for the food project. We expect, of course, that as FHIR develops, so will this profile, and it will probably follow the development in the FHIR standard. The common telehealth infrastructure, as you can see near the circle number 1, red circle, it contains packets, assignments, it contains care teams, which clinicians belong to which teams, it contains measurements, responses, and so forth. It shares with the Danish national health tele infrastructure. It shares data using the health HL7-based CDA structure, document structure. We exchange PHMR documents, which are used for medical measurements. So this could be your oxygen levels, your weight, and so on. And we exchange QRD, questionnaire response definitions, which are the patient's responses to our questionnaires, in a document model. These are existing standards that have been profiled for Danish use. Typically, this mainly means using the Danish citizen identifier and a few more things. Cross-sector, that means we are able to, and you can see that near the red circle too, we can exchange across the country patient measurements and questionnaire responses, common patient data, for example, who are the related citizens to a particular patient, phone numbers and so on, and citizen's address. We have a common patient video appointment list, so we can see when we are interacting with the patient and when the patient cannot participate in anything else. And also our common access log, so that a citizen can go in and inspect which clinicians have actually seen my data. Is part of the Danish healthcare law that you must be able to do this. Other clinicians can use their solutions, so for example, patient journals and so on, and look at the shared data. And other patients than the person who is a telehealth patient can then look at that particular patient's data if they have permission or consent to look at which data has this patient returned in. For example, if I had the consent and I was the related person of, say, a parent, a senior parent, then I could get permission to look at which data my father or mother has turned in using the Danish national healthcare infrastructure. And because this was already built, by ensuring that we exchange data, we get this functionality basically for free. The deployment status, and this is my last slide, is that the common telehealth infrastructure is in place, it's operational, it is running today. The Danish national health infrastructure is of course in place as well. The solution for telehealth clinicians and for telehealth patients is almost there. We expect to be able to roll out a pilot, the very early pilot, initially next year. And the solution for general practitioners is on its way using the Danish national health infrastructure. And we have kept the General Practitioners Union or Association informed about the common telehealth infrastructure, and we have ensured that should they desire to do so, they can then couple general practitioner systems directly up to the common telehealth infrastructure should they desire to do so. And we also have ensured that clinicians in general, for example, hospitals, and patients that are related persons can use the Danish national health infrastructure to connect and see this. Are there any questions, please?
I think there is one question we may be able to quickly answer, Christian. The common telehealthcare infrastructure is owned by whom? Who will the data be the data controller?
The data controller in terms of the data general data protection regulation is the 5 regions and the 98 municipalities. So in terms of who owns the data, that it's the citizens' data that they have given into the 5 regions and the 98 municipalities. In terms of the software, if the question was more related to software, there is a joint license between the vendor of the infrastructure and all of the 98 plus 5 organizations that constitutes the buyer. So the buyer can take this software and give it to a different vendor for further development if they should choose so.
Thank you very much, Christian. So 2 things. I think we need to go on, but just to emphasize, as also illustrated by Christian's presentation, the telemedicine solution that we are talking about here is more complex than just a sheer monitoring aspect of different physiological parameters. So it's a complex telemedicine solution, but there is room for, as mentioned by Lars Ehlers, room for regional variation in how the solution is set up in the individual regions. As you may also have seen on the chat function, we will ensure that we will collect all of your questions. Unfortunately, we have more questions than we have time to answer during this session, but keep putting up the questions, and then we'll compile all of them and ensure that we will share those with the presenters and have some questions for you that we can hopefully upload on the website afterwards. But for now, I think we will need to go on the program. And being a complex intervention that we are now implementing in the Danish healthcare system, we also need to consider, of course, how we can evaluate whether or not this has been a success. And for that, we need to have some considerations of how to evaluate what should we consider and what are the challenges in setting up an evaluation of a telemedicine intervention. And for that, we have invited Professor Lars Ehlers, who is a health economist from Aalborg University. Please, Lars, the floor is yours.
Thank you. So can you hear me and see my slides?
We can.
Okay, thank you. I will talk about the evaluation of this Danish rollout of telemedicine for COPD patients. Just about myself, I'm a professor of health economics and a head of the Danish Center for Healthcare Improvements at Aalborg University. And I've been doing some research about telemedicine since 2010. I have two things that I want to highlight in my presentation here. First is that we need some kind of governance structure, and why is it that we need that, and why is it that it's very good that Peter from the Danish Health Data Authority needs to see himself in that position and why he does that. And the other thing is that why we also need to continue doing our research on the cost and effects of telemedicine, and how we have set up a plan to do that together with the main track. So for those of you who are not familiar with health IT in Denmark, I think we can say that Denmark is one of the most digital countries in Europe. I mean, one thing is that we rarely use cash anymore when we go to a shop in Denmark or a restaurant and buy something. And a part of that is due to the politicians in Denmark who have had national strategies for digitalization and also for health IT, and made national strategies since the 90s. And we have made in Denmark large investments in the internet and in common platforms, common services and databases and so forth. And if you go to the literature, you can read about some success stories in Denmark. I won't go into these, but I have mentioned a few here. And the idea is that this have created the background for a very strong belief in Denmark that telemedicine is going to be the next success story in the health IT agenda in Denmark. And then there are many definitions of telemedicine and telehealthcare, and the particular solution that we're talking about is this one here in the picture. And we have highlighted a bit before in the two earlier presentations, but just to go through it again, we're talking about a patient who can be referred to telemedicine. So you cannot just choose it by yourself. You have to be referred by a physician who say that you're eligible to this service. You need telehealthcare or telehealth monitoring could benefit you. It will typically be the family doctor, but it could also, in certain circumstances, be a hospital employed doctor. And then the municipality nurse or a person sent out from the municipality will train the patient in using the telekit, and also train the patient in a better understanding of their own disease. So it will be the nurse or some kind of IT nurse cooperation with the patient, try to teach them how to use the equipment. And the equipment differ, as we said something about before. And I think there's a good reason for that. And one thing is that the main purpose is to keep the patient out of the hospital, as Peter said earlier. But how that is going to happen is not quite certain, and there might be some discussion about that. This is a complex intervention, and there might be different ways to keep patients out of hospital. And this is also why I believe the kit differ from region to region, depending on what you believe locally might be beneficial. So I will come back to this later, but one mechanism could be that we want to empower the patient. The patient need to learn how to handle their own disease, how to avoid exacerbations. And the basic effect is actually that the patient start to interest about the disease and try to monitor their own disease and learn how to behave, to change behavior in order to stay healthy. Another mechanism might be that this equipment is supposed to give the health professional some data to act on. And in that case, the doctor might have preferences for certain instruments or certain measurements and certain timing of what is going to be measured. And this is why the kit is not specified in this solution. It is locally defined depending on the local strategies for implementing telemedicine. But another important aspect here, I believe, is also, as Peter said, that the responsibility for monitoring the patients is actually transferred to the nurse at the local municipality. So normally you would say that the responsibility for monitoring the patient would be at the GP level. But we know that there is a capacity problem in the GP. So, and we also know that many instances, COPD patients might not call their doctor when they should call the doctor. They don't want to cause trouble if they could, if they should perhaps not have called the doctor. But to be in local contact with a nurse might be easier for them instead of interrupting the doctor all the time. So that was just basic about the setup and the idea about the setup. Then I will talk about the background, because I also think this is interesting to look back at. It all started in 2010 or before that, where a few local studies seemed to indicate that telemedicine was a fantastic new intervention. And I believe that this was not only in Denmark, this was also in a number of other countries, where a number of small trials, small pilot trials indicated that telemedicine could be a way to transform healthcare. This could perhaps be the solution to the problem with the increasing number of elderly people and a reduced number of people to have to pay for public health care. And at the same time, those smaller trials came out with their very promising results. A national action plan was made and a national strategy was made, and a large scale trial was decided. And in Denmark, we launched this large-scale trial in 2014, and in 2015 or 16, at that time, the politicians actually decided that this was going to be a success. We believe in telemedicine, we need to roll out. So they decided that before the results of the trial came out. And I think, again, this was very similar to what happened in other countries. At least I've been told that in the UK, it was a very similar study that politicians decided that this was going to be implemented even before the research community had sort of verified that it was beneficial to patients and it was cost effective in a large scale. And as you can see, due to this, there has been 5 years or 4 years since that decision and until now. And there's a good reason for that, and that was that the large-scale trial was actually not as beneficial as we have hoped for. And again, I believe this was the case in UK as well, which is called the whole demonstrator trial that came out very close to the Danish Telecare North trial, suggesting that this large scale might not be beneficial as such. We need to look more closely into it. It might not be as easy to get these economic benefits as we had hoped for. And what we did in Denmark was to try to look at the data more closely, and we looked at what subgroups might be more beneficial to give telemedicine to, and we found, similar to other countries, that the group with severe COPD was probably the group that were most cost effective to give telemedicine to. This was the group where they were most motivated to change behavior and more likely to act in a different way to keep patients out of hospital. And I think that looking at international studies, the result was very similar. The Danish result was very similar to the research at that time. It was primarily done as RCTs, large-scale RCTs, and systematic reviews also indicated that there was only limited effect on the whole group of patients and only limited effect on admissions and outpatient visits on this large group. So we need to focus. But one of the reasons that we continued in Denmark, I believe, was that we also found other good signs. I mean, the prices of the equipment dropped very much. We just heard about FUT, the large-scale tender that really obtained a lot of economic savings on the equipment, especially on the tablet, I believe. And another thing was that the nurses came back from the municipalities a number of years after the trial had ended. In North Denmark region, the operations went on even though the trial had ended. We didn't take the telemedicine equipment away from the patient. We didn't stop. And after a number of years, the nurses came back and said, well, now we have used it for so long, we can really see the benefits. It just needed us much more time to find a way to make this system work better than we did in the trial period. So here we are now. A national decision to the rollout has been verified again, and we also want to continue to other groups afterwards. We have been talking about that, but I want to go back to this thing that I believe that we didn't do well enough in the research community, because we didn't quite answer why do we believe that telemedicine can keep patients out of hospital? What is precisely the mechanism? And looking at the thoughts that we had at that time, I mean, there could be some on the patient side, it could be some explanations on the health professional or the system side. It could be the empowerment mechanism that we could teach patients to take better care of themselves, to learn to monitor their own disease and prevent exacerbations. It could also be more simple, that it would provide some kind of safety feeling to the patients. Now they have an easy contact to a health professional, a local nurse, where they might even know the face of her and the name, and they can contact them. So instead of being afraid and calling the hospital when they feel ill, they might feel more safe just to talk to the local nurse. On the other hand, it might be on the system side. We might, with telemedicine, be able to produce a more effective system with a higher productivity. We might be better to talk together across sectors. We might be able to use data to act more quickly in order to intervene in the right time to keep patients out of hospital. And why is it important to know? Well, I believe it is important to know because we need to optimize. We need to, if one of the aspects of the telemedicine program is without function, we don't have to invest in it. If we don't need to teach all the patients about the disease, we can save that money in the implementation, for instance. We also want to help the regions, the other areas that might do it a little bit different. So what is the most effective way of doing it? We can learn from each other, and that would be to the benefit of the patients. And it might be also something that we can transfer to other countries and transfer to other patient groups. And this is said already a number of times. we have researched it as a normal pragmatic RCT, and we should probably have included more research on why is this supposed to provide savings? Why is this supposed to be beneficial to the patients? And I believe this is my last slide, because now here we are in 2020, and we are rolling this out in Denmark. You can say this is a huge investment, and this is driven by, we have some research that indicates that for this subgroup of patients with severe COPD, which is the main target group for the rollout in Denmark, this should be beneficial, but we also want to learn to do it in the most optimal way. And this is why we have decided that there should be 2 tracks here. There should be a main track, which should be a governance track. There are a number of barriers in the system. There are a number of health professionals who do not believe in it, who need to be persuaded. There is a variation in the setup in the regions. So it will be very beneficial if we have a authority who can monitor the system and say that in this region it goes well, you obtain the expected savings, and on the other hand there might be another region who's a little bit behind, and we can use that to learn from each other. And of course we also need a research track, because there are a number of answers that we haven't come up with yet, and which this is a huge chance to learn what is the best way to do telemedicine, and how can we improve it and document that it was a good idea. And the beauty of it is that in Denmark we have this IT infrastructure. We have these national data registers. So what we can do is that we can make a cohort study design which is similar in both tracks. So we have the data from each individual patient with a personal identifier. Each time a patient is referred to telemedicine, we have a register that indicates that this is a patient who has been prescribed for it. And when we can follow the patients, we can even compare before and after usage of healthcare resources, and we can define a control group. And after the governance has taken place and it's ensured that this is a good, we can also make the documentation using the same cohort study design, using the same data, so that the research will speak the same language as the governance track. And these are the main elements in the research track. Sabine will talk much more about it, but I believe these are the main research questions that we need to follow up on. First, is there an equality aspect here in the uptake of telemedicine? We could, if we roll this out on a national scale, will it be beneficial for all social group, or will it only be some of the groups who will be using this to the most beneficial way? We also need to look more closely at other aspects of introducing telemedicine as an add-on to the usual care. I mean, does this affect the quality of the rest of the treatment? It might be that it could even improve other aspects of care, because now we are in regular contact with a nurse, and she might be a way to secure that the patient also treated for comorbidities in time. But it could also have the opposite effect. We don't know that yet. And then we need to have questionnaires out to the patient to follow up to see whether this affects quality of life and the feeling of safety, security, and empowerment level. And this will also enable us to see whether these patient-related aspects affect the cost. And finally, we will need to document that this is what we believe a cost-effective intervention in Denmark. So thank you.
Thank you very much, Lars. So this was excellent. I'm afraid I need to be a bit rude as we have a bit of a logistic challenge. The next presenter is actually challenged in the sense that he needs to be at two arrangements or two meetings at the same time. So I think we'll go straight away to the next presentation by Professor Christian Kidholm, and then we'll, if we have time, go back to questions for this presentation. And Christian will give us a presentation about the evidence base underlying telemedicine.
I am trying to share.
Yes. Let's hope it's on the way. It is. All right, Christian.
Okay,
nice.
Can you see it? Because I can't see the screen.
Okay, yeah, we can see it.
Okay.
We actually see it in the sense that you would see it. So we can see both the current slide and the next slide actually.
Okay.
But
I hope
okay,
it's fine with you, because now I can see it, so we better let it go. So I am working at the Center for Innovative Medical Technology at Odense University Hospital, and we have been doing studies of telemedicine for the last 10 years. We have been developing a database for that describes evidence-based telemedicine studies, and I will give you a short introduction to that. We can see that there's a demand for more telemedicine in Denmark. The financing of the hospital is based on the expectation that the number of what's called virtual hospital contacts will be increased, and that includes telemedicine solutions. So the hospitals will get the funding if they do that, if they do follow the expectation and increase the use of telemedicine. In my region, the region of southern Denmark, there has been defined a strategic goal to increase the proportion of outpatient visits by video to about 30%. And that is quite a lot, since even at my little hospital, we have 1 million outpatient visits a year. So it's a large number of video consultations we are going for. And there has been also been studies in Denmark of how does the population see this, and this study showed that 55% of the population would like the contact to help the healthcare system to be digital to a higher degree, and among those who have tried telemedicine, it was 75%. So there's a demand politically, but also in the population. So the question is, what does a doctor or a nurse who would like to use telemedicine, what does this person do in the daily clinical practice? Because you can do a Google search, but you can find thousands and thousands of possibilities. So which types of telemedicine is relevant for my patient? Can the doctor ask? What is telemedicine evidence-based, and where can I find information about the effects of telemedicine? And to answer these questions, we have made this database to help clinicians to identify evidence-based telemedicine services. So this is what the database looks like, and you can go into it. It's completely free. So you just enter telemedicine.simt.dk, and then you can go into the database. And I will briefly show you how it's done. So firstly, you select, you can say, well, I would like to know about studies from Europe, studies showing a positive clinical effect. You could say, I would like to know what's been going on within cardiology, and I could like to know about how can video consultation be used for that purpose. The database is, of course, based on a PubMed search. So we have done a search about telemedicine defined as the delivery of healthcare over a distance. between patients and hospital staff by use of information and communication technologies. And we have only included randomized controlled trials and trials with a control group so that the added value of the service can be identified in some way. And we found 3,000 hits, and of these 331 is included in the database. This is what you get when you do a search. This is a search for studies within diabetes. So each row is a scientific article in the PubMed database, and you can get information about what is the diagnosis of the patient, what is the intervention, what is the intervention about, what is the technology, and for the technologies we have used icons, as you can see in the lower left corner. So we are sort of dividing the services into, is it apps, is it video consultation, telephone, home monitoring, SMS services, or homepage? So there's a sort of a simple app, a simple icon that describes what it's about. And then for the outcome of the services, we have sort of tried to make color codes. So a green color means for the clinical outcome that a positive and statistical significant impact has been found on the primary clinical outcome. So, and again, of course, the red color identifies a statistically significant negative impact on the clinical outcome. So you can kind of easily see, is it what has been the outcome of these services, and also has there been any kind of reduction in the use of healthcare services, and that is in the economy. The second last column, you can see, has there been an impact on the economy, and you can also in the last column see, has there been implementation challenges identified. So briefly, what does our database show? Well, it shows that evidence-based telemedicine can be found within 22 medical specialties. About almost half of them find a statistically significant improvement. Half of them find that there is no statistical difference in the clinical outcome, and only 2% find a negative impact of telemedicine. So this is, of course, very interesting that negative effects are quite rare. And before the pandemic, we were really looking for improved clinical outcomes. But I think in the case where we have the pandemic, we just want to produce or give patients telemedicine, and thereby offering them some kind of service in case they can't go to the hospital. So even a non-significant result is also of value, because that can be the basis for moving treatment from the hospital to the patient's home. So I think the consideration should be, well, firstly, that these services generally do not harm the patients, and secondly, that it should be considered whether the primary outcome should be a clinical outcome, or whether it actually should be outcomes in the form of increased empowerment of the patient, increased patient perception, increased self-efficacy. So that was the clinical outcomes. Now, what about the patient perception? About half of the studies has been looking at and studying the patient satisfaction or similar, and we can see that 73% of the studies do show positive patient perception. So generally the patients think this is a fine service, and I think we need more studies in this area. And actually, in my view, this is where we can find in most European countries, the true value of telemedicine is improvement in making the life of patients with chronic disease more easy to handle, and improve the patient's ability to control their own lives. I think that is where we see sort of the true values of these services. In very big countries like Mexico and Canada and Australia, telemedicine can be about saving lives, but in many European countries, telemedicine is about improving the quality of life and patient satisfaction and empowerment. What about economics? Well, half of the studies are assessing some kind of do have data on is there an impact on the patient's use of healthcare services, and of these about half find some kind reduction in some kind of healthcare services. This is not the same as to say that telemedicine in general saves cost. This is just saying that in half of the studies we can actually see that telemedicine reduce some kind of service. In many studies of telemedicine, even economic analysis, they do not include the cost of the telemedicine service. And therefore many studies of telemedicine, economic studies, are biased. And we could see, I have here shown 3 examples. You can easily see that many telemedicine services are quite expensive. So if they don't take that into account, they might end up that telemedicine is adding cost to the healthcare system. But in my view, we have learned from this. We have learned from these very expensive studies, and we are starting to use services in which you can call bring your own device. So we are using the fact that many patients have smartphones themselves, and this reduces the cost quite a lot. We have also seen implementation challenges in many of the projects. At the moment, I'm talking to the clinical departments at my hospital to see how can they use the database, and could there be value for them in using these services? And here are the comments I get. Some are saying, well, this is not for all patients, and they're quite right. It's not for all patients. It's for some of the patients sometime. They're also saying that we need training and that it has to work every time. So there might be some technology problems that need to be solved and some training problems. And quite often they end up saying, well, maybe we should start with this patient group, and they actually have been thinking about a patient group for which, for instance, a video consultation could be relevant. So you might meet medical doctors who will say, well, telemedicine is not evidence-based. Well, that's not true. Many types of telemedicine is evidence-based and is based on randomized controlled trials. And you can use our database to find the services that is relevant for your patients or your hospital. Thank you very much.
Thank you, Christian. Do we have time for one quick question? Just what is the, are you planning to keep this database updated, or what?
Yeah, we are currently in talks with potential sponsors to find money for updating the database. And we can also see that the number of studies in the PubMed database is increasing. So there's lots of new data to include in the database.
Exactly, and I think it would really be a value to have such a user-friendly database that would be, kept vital, so to say, also in the years to come. Thank you so much, Christian. And I think we need to go on, unfortunately. So we have one final presentation, a short one, and we've talked about evaluation and the linkage between research and implementation of telemedicine in routine clinical practice. And our last presentation will be exactly on that topic, given an example of how to, in practice, evaluate implementation of telemedicine using scientific methods. So it will be a presentation from an ongoing, just started PhD study by Sabine Mikkelsen-Ravnsbach from Aalborg University. So Sabine, the word is yours.
Thank you, Søren. So can you see my slides?
We can. Yes, they are now in presentation mode. Perfect.
Good. So thank you, Søren. My name is Sabine, and I'm employed at Danish Center for Healthcare Improvements at Aalborg University. and I'm an upcoming PhD student, and that's what I want to tell about today. So the aim of this PhD project is to evaluate the nationally implemented telehealth care for COPD patients in Denmark. And the PhD study consists of 4 sub-studies, which all will address different aspects of the effect of the telehealth care solution. The first sub-study will investigate the uptake of the treatment. It will look at which patients receive and accept the telehealth care solution in relation to age, socioeconomic status, and location. The second sub-study will look at the clinical effect, for example, admission rate, municipal services. It will look at quality of treatment and costs. The third sub-study will look at patient-reported outcomes. It will look at the quality of life, feeling of safety and security, and in empowerment. And the last sub-study 4, will be a health economic evaluation, which evaluate telehealth care in a real life practice, and it will try to incorporate results from sub-study 1 to 3. So we expect that this project can contribute to the experiences with the use of telehealth care to COPD patients, and furthermore to get experience that can be used to other disease areas. We also expect that this could improve future treatment options for COPD patients. And lastly, this will be a critical assessment of telehealth care in a real-life practice. So this was a very short introduction to the project, and you're welcome to contact me if you have any questions about the project. And furthermore, I have included some supplementary material on the 4 sub-studies. You will get that after this event. Thank you.
Thank you so much, Sabine. So now we closing up on this was actually all of the presentations, and we are nearing the end of the program. Before leaving or giving the word to Henning, I would like just to say thank you to all of you participants for taking part of this, and of course to all of the presenters, and also to my colleagues in Mette Falstig Jensen, and in particular to Henning Boye, who has been really the driving force for setting up this meeting. So now I'll give the word to you, Henning, for any last questions and closing remarks.
Yes, thank you. And the sun has set now in cold Denmark. Thank you very much, presenters. Thank you, participants. As we said and wrote to you, we will upload the presentations and the recording of the entire session. And then also we will collect the comments and the questions you have, and try and have them answered by our presenters. But we do have time still for us to pick out some of these. I could take, there was one question about whether this, the infrastructure solution, could it be ported to any other EU country? Are you there, Christian Callison?
Yes, indeed.
Yeah, what would we say? What would you say about the portability or the transferability of this?
I believe it is highly portable. So it turns out that the way that the user login part is fairly decoupled from the rest. And there are a few other integrations between the infrastructure to national registries that could probably also be dismantled. So I would believe that the core of the common infrastructure should be highly portable to other countries as well. Of course, centered around this is the so-called Happy Fire server, which is the entire API. That's a very modular server. So even though we have a Danish profile, I believe it is possible to create, say, a German or a British profile on the Happyfire server and use that instead.
Thank you very much. I have there's another issue. This is about as Christian mentioned, that if we search in PubMed or other databases, it can be somewhat biased, the results that we get out of that. For instance, in Denmark, we had a telemedical study which showed adverse events. Now, this is not really, it's not indexed in terms of adverse events. So this is hidden in the, I would say, this is hidden under the telemedical labels. So therefore, you have really to find, you have to study each of the reports in order to pick out the, I would say, the adverse events. We had in the Danish presentation of this, we also had a presentation of patient safety and quality. So I just wish to enter this also. I see no further questions in the line of the chat now. So I think we will conclude this. And then if any of you participants have further questions, you're welcome to write to us and we'll direct them to our presenters. So I think this would be the end of that. If you have any questions about how to access this, just write to us. So thank you very much. It's been very interesting. It's been, we have had 125 participants from all over the world. So we look forward to be in contact with you further. Thank you very much. Søren, will you sign out?